August 28th, 2019, and it is 5:32. As the quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business is citizen communications. Anissa? Anise?
Hi, good evening. My name is Anais Cruz, Central Health Communication and Community Engagement Program Manager. We only have one person signed up to speak today, and I would like to introduce Sam Ruiz with the Lions Club. Right here.
Thank you. The reason that I am here is just briefly let you know that the Lions Club is very much involved in eye screenings, and we're very much concerned about being able to provide the services through Travis County. And we know that there are areas in which we can benefit from. And so I will talk about focus. Our whole focus in the Lions Club is to have a clear perception of vision screening and testing, which is a major concern for kids and adults in the Travis County area. Our purpose is intent and plan to seek medical providers such as Central Health to partner in order to provide eye screenings and eye exams as determined by Central Health providers. We are asking and requesting consideration that the visual screening be included as a vital medical issue, and I believe that the vision can be administered in a way in which we can partner together and do so. So in all, the solution for our Lions Club is to work together with Central Health, providing a program to get glasses for kids and adults. Currently, we are going in different directions, but I believe that there's a way that we can go. And so when I see Central Health medical plan, Central Health care, I think in terms of an umbrella. And so what we would like to do is see if we can have vision be part of your umbrella so that we can fall underneath and go as well, because we believe that vision screening and visual issues for kids in schools and adults is a major, major concern. So we would like to try to fit in your umbrella. Right now we're doing a lot of work, and most of the work we're doing it with raincoats, and so we would like to be under a complete umbrella.
Thank you, Mr. Reese.
Oh, I am a health champion, current team, and enjoying it, and that's probably one of the reasons why I'm here. So I belong to the health champions, and I'm having a good time and enjoying it.
Thank
Sam.
you.
And the whole family.
And that concludes citizens communication.
Thanks. All right. Thank you for coming tonight. I'd like to take a note for the record that agenda items 9 and 10 will not be discussed this evening. Those items are expansion, including project bids and or occupied property or potential property for acquisition or lease in the downtown campus and properties located in eastern Travis. I'd like to note that the agenda will be taken out of order. The agenda order will be as follows: item 4, 1, 2, 3, followed by the consent agenda, then agenda items 5, 6, 8, 7, and finally 11. Everybody get that? You got it? Okay, all right. Okay, the regular agenda. Agenda item 4, discuss and take appropriate action on the interlocal cooperation agreement between Central Health, the University of Texas at Austin, and the Emergency Services District 11 for the establishment of a healthcare clinic in southeast Travis County. So this is an action item. Mr.
Point of information, as we go through our agenda tonight, because it's rather long, is it conceivable, and I don't know if this is a legal question, to put a time limit on our discussion per item?
You may do so. You may make a motion.
I'd like to propose that we limit our discussion on each item, with the exception of perhaps the budget item particularly, to a limit of no more than 15 minutes.
Do I have a second?
A second.
Manager Bell. So we have, hold on, Dr. Manager Marlos. So I have a motion by Manager Jones, seconded by Manager Bell. Any discussion? Manager Bell does.
Yes, I'd like to, I would support that if we also excluded this particular item, item number 4. because I don't know whether or not item number 4 is going to have to be, some of it will have to be discussed in executive session or not. If we're going to speak in public, well then, I think that there are some things that should not be necessarily shared in public, and I was hoping that if we have to go into executive session, I don't want us to be limited by a 15-minute discussion on an agreement that is already in its 5th iteration.
Just, Chair, Vice Chair.
So would it be acceptable to you, having made the motion, to make some allowance for any items that have to be taken up in closed session?
Yes, I think that would be
Okay,
appropriate. but
so I
saying-
would move to amend that.
Thank you.
Do you want to make the motion to amend?
Yes, I
A
move to
friendly
amend
amendment?
the Manager Jones' motion that items be limited to 15 minutes except for the budget discussion.
And,
And
item.
any item that we would have to discuss in executive session.
In closed session.
okay.
Second.
Okay, so we have Manager Valdez making the motion, seconded by Manager Greenberg. Any discussion on that?
I just ask that the legal team or someone identify the 15 minutes when we get to that to make sure that we're approaching that. I think it would be appropriate.
Manager Musaitif?
Question, clarifications. So the 15 minutes, does that also entails, or if we go into executive session as well?
No, we just excluded closed
I just wanted to
session.
make sure to clarify. Thank you.
All right, so we have a motion on the floor. Any other discussion? All in favor, say aye.
Aye.
All against? Any abstaining? Motion passes. Thank you, Manager Jones, Manager Valdez, Manager Greenberg, Manager Bell. All right, Mike and Larry.
Thank you. So I'll kick it off and hand it over to Larry, and then we'll have Holly walk us through the terms of the agreement. But this is something that we've been working on for some time, and I want to thank Dr. Morgan, who's here with us this evening. But this is about establishing clinical services for primary care services in Southeast Travis County. And when you're looking at this this evening, you know, understanding that there's a lack of infrastructure out there, and going back to the early commitments, even dating back to 2017, and then reaffirmed again at the end of 2018, it was about reaching out to those underserved areas that were lesser resourced, but also just simply didn't have the infrastructure. And so that's what brings us here this evening. But Larry, did you have any comments on it?
Yes, I'm Larry Wallace, Chief Administrative Officer, and I'm aware we have 15 minutes, so I will be very brief with my comments. And all I want to say is this particular project has been very challenging for us, and the reason so is we have third parties that are involved. It's a different model, and so we've had to take the time to learn as we go. We wanted to be sure that we accomplished the public purpose with this project. We needed to understand the construction process and make sure we had controls in place because of the nature of the project. We were concerned about fund controls, how money is really exchanged. We don't own the land with this project. So it was really important that we work with Dr. Morgan to try to answer all the questions that really came up in due process as we did this work. I want to commend Holly. She worked very hard. She put hours in research to make sure that what we ended up with was something that could pass muster. I want to acknowledge Stephen Lamp, who in the early stages also contributed, as well as Melissa Zapata. So with that, I'm going to relinquish, and I think Holly will take it from there.
Great, I am going to pass around for the managers a hard copy of the agreement. So just take one and pass it down, or a slideshow that I'm going to go through with you. For the most part, it will tell you what page to look at in the agreement, as well as what section I'm talking about. Just for background, because You heard Manager Valdez mention that this is the 5th iteration of an agreement. So the iteration before was a ground lease agreement between Central Health and ESD 11, which would have given Central Health a lease on property located at 7300 Kellum Road. And we intended to use that property to sublease to the University of Texas School of Nursing. We would have built a clinic on that site, and then UT School of Nursing would have occupied the clinic and provided services. But now that that lease is no longer, we are looking at a three-way agreement, which we call an interlocal cooperation contract or interlocal agreement between Central Health, ESD 11, and the UT School of Nursing. And so, starting with Section 1, Section 1 is the largest part of your agreement, and this section sets out the obligations of the three parties respectively. So from pages 2 through 4 of the agreement, you will see Central Health's responsibilities laid out, as well as ESD 11. And just for reference, in this agreement, ESD 11 is abbreviated as TCFR, which is Travis County Fire Rescue. So anytime you see that, that's ESD 11. So what are the responsibilities of Central Health and ESD 11 here? So Central Health will inform MAP enrollees of the clinic's existence once it's established and services, and will further inform the School of Nursing of any land purchases it makes within 5 miles of that location. I'll talk about the money commitment in a little bit, but that is another obligation of Central Health. ESD 11 will contract with qualified firms to perform the necessary engineering and construction services, and will be required to cooperate with the School of Nursing in designing the clinical space. Because the School of Nursing is going to be operating the clinic, they know best what the clinic needs are. ESD 11 will submit monthly construction progress reports and documentation showing the true cost and expense of their construction work to the School of Nursing. We'll talk a little bit more about that on the next slide. ESD 11 will also obtain all building, development, and use permits for the site, and will finally maintain and repair the land and the clinic's mechanical and electrical equipment or systems at no cost to Central Health or the School of Nursing. So this last point is important because under the ground lease, Central Health would have had responsibility for maintaining and repairing the clinic and all of the systems inside of it. All right, so continuing with obligations, now we're going to look at the School of Nursing's obligations, which begin on page 4 and continue through page 8. So I'm just highlighting some of them here. There's a lot more detail in your agreement, but they are to design the clinic to provide adequate space for healthcare delivery. They are going to oversee the construction of the clinic through an employee of the UT Construction Service Department, so someone with expertise. I'm getting older and I definitely need my glasses. They will verify all invoices, cost and expense reports that ESD 11 submits for reimbursement, and all of those invoices have to meet the conditions that are set forth in section 1.3.10 of your agreement. There are a lot of conditions, and I didn't want to fill the slide with them, but you can take a look at what those conditions are. To Larry's point, they're inserted to help us make sure we control the costs and that the costs are appropriate and allowable for Central Health. The next point on this slide talks about the kind of healthcare services that the School of Nursing will provide. So they've agreed to provide CLIA-exempt laboratory services, primary care for adults, pediatric care, women's health services, and hopefully behavioral and mental health services. I would like to note that they may ask another provider to step in and help them with some of this. It may not be solely them providing services. The School of Nursing will submit reports to Central Health on the number of MAP enrollees served at the clinic, so you'll know how your investment is doing. And finally, they will engage in patient outreach activities and pay the utility costs associated with the clinic's operations. So here's the other Central Health obligation, which is part of the compensation section on pages 8 and 9. Central Health has agreed to pay up to a not to exceed amount of $1,150,000 during fiscal year 2020, which is coming up right around the corner. You're going to hear about the budget later tonight. $250,000 of this amount could be used for clinic equipment, signage, or marketing. Doesn't have to be, but it's available for that. No more than $92,500 of this amount will be used to reimburse for specific types of work like earthwork, paving, and engineering services. And that number was based on, pro forma is probably the wrong word, but a document that was developed during the due diligence period of the ground lease. The remainder of funds can be used to reimburse ESD 11 for survey, design, and direct or field indirect construction costs. And as I mentioned earlier, costs and expenses have to be reimbursed at actual cost, no markup or overhead. Section 3 is our auditing and repayment section. So we talked a little bit last week about the ability of Central Health to perform an audit of all records that would illustrate the costs and expenses of construction. And that audit right lasts 4 years after the end of the agreement term. If an audit were to disclose that Central Health overpaid or paid for maybe a non-permissible cost or expense, then School of Nursing or ESD 11, most likely ESD 11, would be required to repay that amount of money to Central Health. Additionally, and this is a completely separate thing, and thank you for Dr. Morgan helping me make this agreement clearer, ESD 11 would be required to return all or a portion of the entire compensation paid if any one of the recoupment events happened. And so if you'd like to see what the recoupment events are, they're on page 10 of your contract. And I do think that they're important, so I'm going to go through them with you. So one is, it's actually at the bottom of page 9, that clinic construction must commence by January 1st, 2020, or another date that all the parties agree to, but that date can't be any more than 90 days from January 1st, 2020. And that helps us expedite clinic operations, because I know how important it is for the board to see services in that area of Travis County. The second condition is if the clinic fails to open by September 30th, 2020. Now keep in mind that weather and other things can delay, so there is a force majeure provision, which is a fancy way of saying if there's things that happen outside your control, that's an excuse. The third is if the School of Nursing vacates the clinic or abandons the lease that they have with ESD 11 before the end of the contract term, and Central Health would have the right to step in their shoes if they wanted to. The fourth is if ESD 11 defaults or is in breach of its lease with the School of Nursing. For example, if they lock them out and no longer allow them to go, that would end the building. The fifth is if the School of Nursing fails to provide care to MAP enrollees pursuant to a healthcare service agreement executed with either the CCC or Central Health. And finally, the last condition is if any of the certifications or warranties in this contract that are made were misrepresented, false, or void. So those are the conditions that would trigger a repayment. And you'll see on page 10 there is a repayment schedule in 3.3. Okay, section 4. Part of the money that can be available for this agreement is for furniture, fixture, and equipment. That's what FF&E stands for. Thank you to Stephen, if you're in the audience. Any furniture, fixture, or equipment purchased with Central Health funds will be owned by Central Health. And the School of Nursing will be responsible for maintaining, repairing, and replacing the equipment on a schedule that will ensure the equipment maintains a safe operating condition for our patients. Section 5 on page 11 talks about the ownership of the clinic. As Mike mentioned, ESD 11 will own the clinic. They own the land as well. And then section 6, which is your notice and dispute resolution process, is the standard process for disputes. It starts with notice, followed by a period of negotiation. If negotiation fails, you would move to mediation. And then if mediation failed, you would move to litigation. Last slide of content here for you. Section 7, which starts on page 13, talks about outcome measures. So one of the things the parties agreed to is that Central Health and the School of Nursing would develop performance standards for our MAP population. And those standards measure 4 different things. One is access to healthcare services. How good are we at getting our MAP enrollees in and out of the clinic? The second is clinical quality. The third is patient experience, because there's one thing to get people in the door, it's another for patients to be satisfied. And the last is diverting people from hospitals to the clinic. Section 8 is the term of the agreement. That starts on page 13. This agreement has a term of 5 years from the date the clinic opens. Remember, that should be September 30th, 2020. There are no extensions, but the ILA could terminate sooner if the clinic does not open by September 30th, or any party initiates termination under Section 9. So I have included some of the highlights of Section 9 here, which starts on page 13. Any party may terminate the ILA for failure to perform the obligations described in Section 1. Those are the things we talked about earlier this evening. ESD 11 and School of Nursing have an independent right to terminate the ILA if any of the 4 defined events of default occur, and those are very likely to occur. They are things like if Central Health was dissolved. And then the last is Central Health may terminate the ILA if any of the certifications or warranties made in Section 10 are misrepresented, false, or void. And of course, because this is a 5-year agreement, we always have to retain the right to fund out. And I hope I did that in 15 minutes, but that is my presentation for tonight.
Ms. Ledger, do you have a question? Sure.
Thank you. Appreciate it. I have a few questions. So in terms of Central Health, we will not own the clinic, and we will not have a say in what the clinic will look like. Is that true?
So we will not own the clinic, that is correct. There will, in your agreement, there are meetings that will occur between the School of Nursing's construction representative, ESD 11, and Central Health. We don't have a veto right, so if we're not happy with something, we can't veto it, but we won't be completely out of the loop of what construction looks like and what the design is.
But we will know, but we will not have the right to make any changes to what the current development or
Correct.
design of that structure. Okay, who will review well, we're not gonna have a say, so whatever they're gonna be, the construction of that building, would there be any point of us, so who will be reviewing the documents of the construction? Would it be us or School of Nursing? Who would it be?
So one of the things that School of Nursing is obligated to do, and they're assigning someone from their construction department to help with, is to oversee the construction. They will look at all of the documents.
And what's the capacity of the number of patients that they expect to see?
That question I can't answer. I do remember seeing 13 patients per day, I believe, during the first year, and 18 patients per day during the second and third year. But if Dr. Zamora would like, he can recognize Dr. Morgan, or
Sure.
might know the answer.
Dr. Morgan, would you like to come up?
You need to stand here.
At the desk.
Okay, can y'all hear me? The original numbers for a provider to have a full panel, we were starting at 50% and going up to 100% within 5 months, and the high end is 17 patients a day per provider. The original start is to put 1 provider in and then to add another one, and then of course as we meet the need and grow the population, and we're maxed out at 17 patients a day, within 24 hours, we want patients to be able to access appointment within 72 hours of accessing an appointment. So that's kind of our gauge as far as when do we need to add another provider. People can't get in. We anticipate patients having 2.5 visits a year. So 17 is the short answer. That is how many patients a day 1 provider will see. That was what the numbers were run with.
Okay, another question, actually, you can answer it. So you mentioned providers.
Yes.
What's the licensing of that provider?
So the provider advanced practice nurses, which should be family practitioners, pediatric nurse practitioners, and then we have oversight of physician. And then as we grow to be able to start bringing part-time of a physician on staff regularly, our oversight physicians right now do work with us in the summer and see patients.
So a nurse practitioner in the state of Texas can perform the same
Yes.
procedures and prescribe medication as a physician, or do they need a physician on site?
They do not need a physician on site, and they can prescribe and they can treat, and
Okay.
yes,
Thank you, appreciate
you're
it.
welcome.
Vice Chair?
I just wanted to follow up on that question of how many encounters per day, because it wasn't
Yes.
clear to me, and I may need Stephen too, we'll see. So you were saying that is a provider defined as one person, one nurse practitioner?
Yes.
Okay, so you're saying that in the beginning, you would have one nurse practitioner there at this site, and that nurse practitioner would see how many patients per day?
So at the most, they would see, we're shooting for 17. Right now, our practitioners see 17 to 20, depends.
Right. Okay. Is there a reason that would only start with one nurse practitioner? What's the capacity? How many rooms, or how many could you have at one time?
Right now, what we have slated in some initial drawings of the clinic were to have up to nine patient rooms.
Right.
And so we can, our current plan is to move the current book of business that we right now have at the Children's Wellness Center over to this new clinic. And and that one provider would come. And then as soon as that instantly gets filled, we would add another additional provider on board. So doing the pro formas, we did start with one, and then we started also at a lower percent and ramped it up. Within 5 to 6 months, maxing out. We could max out sooner, but we were trying to be conservative.
9 times 17 is maxing out, is
Not, well, one provider usually needs 2 rooms if you're gonna be
Okay.
efficient with them. Some places say 3.
Okay.
We will have students there as well and other interdisciplinary folks, but so really 2 rooms to 1 provider would be the plan, because we run 2 rooms right now with 1 provider.
Okay. So I'm just trying to run the numbers as we're talking vis-a-vis, and this may be actually a Jeff question, but the cost that we're putting in to create this facility. I understand we won't own it, but we are putting in the cost to build it, right? And then there will be cost to us for the service provided that we are, from a cost-benefit standpoint, getting what we in the community need out of it vis-a-vis the money that's put in.
Correct.
Yes.
And I don't know if Jeff or anybody else wants to weigh in on that, or Mr. Giesler.
Well, that's correct. So there is an investment to establish the clinic, and then would be through contracts with UT School of Nursing, which we currently have right now through the CCC, but that will transition over to Central Health, where you're paying for reimbursement for services that are rendered within the clinic. And on the establishment of the clinic piece, this is a concept that we borrowed from what we did in Jonestown with Lone Star Circle of Care, where
Right,
we funded
I remember.
tenant improvements, with the trade-off being that there's some type of payback mechanism if for whatever reason it doesn't come to fruition, but this one's different, but it takes off from that original concept.
So, yes, I remember when we did that in Jonestown, there was a strip center, and that space had to be renovated. But I guess my question for you is, hearing what you just heard about the ramp-up, is this a reasonable ramp-up and number of patient encounters vis-a-vis the investment?
I think I'll start off with just a general framework about how I'm looking at it, but then, again, we may have to get back with the board in terms of more specifics, but as this clinic gets started up, and there's always gonna be a startup period.
Sure. Absolutely.
You've already got some patient relationships established already out there with the pediatric side, but at some point, we're gonna know, once this clinic gets up and running, what's the baseline? What is this true capacity? And then we'll be able to start calculating, what's the cost per encounter compared to other similar
Right.
advanced practitioner sites like what we have in Jonestown. But then compare that to, all right, even on other care delivery models, what does that look like? And I think anytime that you're in a startup period like this, and a lot of it depends on what the ultimate payer mix is. You know, your cost per encounters are probably going to be higher than what they would in an established FQHC, for example. Just to be perfectly
But we would,
clear about it.
but we'd be able to benchmark this against Jonestown, which also has a similar,
Well, I use this
Provider.
as an example, that's.
but, or other nurse practitioner,
True advanced practitioners, if
advanced
I
practitioner.
remember correctly.
Yes, sir, there are two, it rotates on a 7-day-a-week model.
Okay. So, you know, we'll do the best we can to try to get to an apples-to-apples comparison.
Okay.
Good.
Yeah, yeah.
Did I see your hand up, Manager? Is it good? Manager Jones?
Yes. Yeah, I have a series of questions I want to ask. First one is, the contract we will have, is this with UT or the University of Texas School of Nursing?
So it is with the University of Texas at Austin, but they're acting through their School of Nursing.
But the contract is the University of Texas at Austin.
If you look at the first page, at the top here, what it says is it's entered into between the University of Texas at Austin on behalf of its School of Nursing.
Okay, but from a legal point of view, that means it's with the University of Texas at Austin.
Correct.
Okay. Okay, the second question is, so this is gonna average about what, $230,000 over the 5 years for the investment, is that 1.15 million over 5 years?
Took it out over 5 years, but
Is this is a one-time investment, is that right? Or am I-
Yes.
that's correct.
Yeah, so
Yes.
that's about $230,000 of taxpayer dollars that we're gonna be investing in this area. I just want to make sure I get the numbers right because,
Use a 5-year basis, yes. I mean, you could take any number, you know, factor in. I'm sorry.
They're gonna use it before 5 years.
That'd be my,
This is the capital cost. We're talking about
This
the
is
capital
capital
cost.
yes, just the capital cost is what I'm
Right.
looking at. Okay. And I understood it was for 5 years, so after the end of 5 years, do we have is the understanding that will continue and operate?
Where do you get the 5 years?
The contract.
Con-
The contract,
Contract says that.
5 years.
Oh, okay.
So at the end of 5 years, the obligation to repay Central Health the funds is extinguished. There would still be a separate service agreement between either Central Health and the School of Nursing or the CCC and the School of Nursing.
Okay, but no more upfront investments at that point is expected for capital items?
Correct.
Okay, yeah, that's what I was just trying.
the other answer, or the other piece of the answer to the question, Manager Jones, is if you get past, and I'm just gonna say, let's say a 3-year period, and we get a good sense, because then you'll have two, you know, you have some startup period, but then you'll have at least 2 years of year-over-year data at that point. I think you'll also have a sense about, all right, what's the shelf life of this clinic? Is it 25 years? I mean, I'm not sure how long you've been out at the Del Valle ISD, but it's well over 20 years. So then you gotta figure out the shelf life of this clinic, and so you have these upfront capital costs, and you have the encounters over some period of time. You could easily take 10 years, or you could take 20 years. You just have to know, oh, this is what the financial viability looks like for this particular clinic model. And then you can start adjusting, okay, this is what our actual cost per encounter was, based on the shelf life of the clinic, as we know it today. And then you can turn around and compare that to, okay, how does this compare to other similar provider models that also have that kind of shelf life with similar provider levels and service levels, et cetera.
Okay, no, I appreciate that. The reason I asked the question is because concurrent with this process, it is my understanding that we're looking at developing a full-service operation out in southeast Travis County beyond just this clinic. So the question is, we're gonna invest 1.5 for this startup, and then we're looking long-term for building another facility that will be out there. The question I raised is that if we continue this beyond the 5 years, which I assume we will, and we're building this new facility, is the planning effort we're talking about gonna be coordinated so that we have adequate facilities out there or not, and not overbuild?
Right, and that was a question that came up yesterday in the county commissioner's court with Commissioner Gomez, and the response was, And actually, she was asking from the standpoint, would there be more potentially invested in this? Right now, we're at 1.15 million. And so what we would do, especially when we think about community care is already at capacity where they are in the temporary clinic and needing to provide expansion for community care on this, is we're gonna have to, and it's not just about building, it's about looking at what the overall need is and what the capacity need is, but making certain that, as we expand, for instance, for community care, that we're taking into account the totality of the assets and what that capacity is that we bring to the table. So it's a pretty robust business decision-making process, but also making sure that we're connecting with the community too. What is it that is changing out there that would necessitate what the footprint might look like and the programming might look like in any given clinic setting?
Okay, just two other quick questions. One is, I thought, and help me recall, I thought at one time at our board meeting, maybe it was a session, which we're in, what is it called? Closed session, thank you. That we had decided we were not going to proceed with this.
Well, you wouldn't have decided anything.
No, I didn't say we decided, but I guess my question is, this has been brought back up after I thought that we all left the meeting with the understanding that this was not going to go. So I just had some concerns about how did we get back here when I thought there was consensus of board members doing that even though we didn't vote and we didn't reach any legal agreement, that we said that, well, let's look at other options.
Right. And council, I have to ask for advice on this because Manager Jones is bringing up a topic that was discussed in closed session. How should we proceed on this?
So I think you're asking why the agreement today looks maybe different than what we talked about in the closed session.
Kind of, sort of, yes.
And if I may, kind of going back to your prior question, because I think that informs, ultimately what our strategy is here. We had an outward-facing commitment to the community, actually dating back to November of 2017, where some expectation was set that something would be put out here because this area was under-resourced and, compared to areas that were in the urban core. And once that expectation was set, we wanted to do everything we could, and this is our third major iteration of trying to work out some kind of an agreement. But I know Dr. Morgan shares his passion as well. We wanted to do everything we could to make good on that outward-facing commitment. Now, because we were not able to successfully bring together a partnership with an FQHC status, that has us in the position of looking for other options for that FQHC that's out there right now in that temporary facility. And so the other options piece is still very much on the table, but that necessitates finding a piece of property at fair market value that is certainly affordable, and we've got the necessary letters of intent and all the business diligence in place from an FQHC operator to make that possible. So there's, I just listed off five risk points right there. Any one of those could derail this. So by having this presence out here, they've already got a presence established, then at least we get something out there and we can make good on the commitment to the community while we're still looking for these other expansion options.
And you're comfortable that the ESD will provide the necessary type of facility we're talking about to do what Dr. Morgan has indicated that she needs to do?
That's my read on it at this point, and there's a number of obligations, and quite frankly, we've shifted some of this, what I'm calling approval risk, over to UT because, one, it's an open book development, so we need to see what the costs are, right? But two, we're relying on UT to tell us, yes, what is being constructed out there is in fact an operable clinic space and not something that's not going to work for the providers and the patients that are going to be out there.
Okay, just two more questions, I'm through, sir. ESD will also maintain and repair the land and clinic mechanical and electrical equipment at no cost to Central Health or the School of Nursing. If there is an injury on the property, someone dies or something, who is legally responsible for that? Will that be the School of Nursing, will it be ESD 11, or will it be Central Health?
And I'm sorry, can I clarify the question?
Please.
Are you talking about passes away within the clinic or just on the property in general?
Medical or?
Slip and fall,
Yeah,
or
if it's slip and fall, they have a,
slip and fall?
So when we start talking about liability, that is addressed in section 13 of your contract. And 13.3 states that neither Central Health nor Travis County Fire Rescue will be liable for injury to any person or damage to any property that occurs or is sustained on the land by the School of Nursing, its employees, its invitees, which would be patients, its licensees, its visitors, or any act or omission, or for any other person, essentially. So it would be on the School of Nursing or UT at Austin to be liable for those things.
Okay. And then my last question is, in the audit section, it says, if an audit discloses the Central Health overpaid ESD 11 or paid for non-permissible costs or expenses, ESD 11 or the School of Nursing would be required to repay the amount of money that Central Health overpays. That's somewhat iffy. So who will determine if, because I could see finger pointing, no, it's you, no, it's you. How is that going to be resolved, I guess?
So practically speaking, if money was paid to the School of Nursing, for example, for equipment, and we find out later that that equipment was $100,000 in cost to the School of Nursing, but we were charged $103,000, we would start with the School of Nursing. But we would have the right to go after either party for that money.
Okay.
All right, do you want to call the question?
Yes, we've reached the time limit. Call the question.
Well, we didn't put a time limit on this one. I think it was the other one.
I was under the impression that we were not putting a time limit on this particular
Yeah.
issue, and it's an action issue. Otherwise, I would have said, modified it so that each board member that had questions would have the same amount of time allocated. You don't have 3 board members or 2 board members ask questions, and no one else gets to
I
ask.
was just going by what,
Well, that happens all the time.
No, we just need to be fair. It doesn't happen all the
You
time.
sit
I
down.
was just going by what staff thought the language was. So,
So is there, okay,
no, there's no motion, so we can't call the question.
Yeah, Manager Valdez.
okay, so, first and foremost, I apologize for having to leave early last meeting, last Wednesday, so I didn't get to hear all the conversation that occurred in executive session. But I am concerned about a couple of things, and that is that this is our 5th iteration of an agreement that we've never seen before, to my knowledge. Has anybody here on the board seen this, anything like this before? So we're seeing it for the first time today. And, I have brought this up several times, that I am one of those board members who does not like being given legal agreements, or us having to vote on legal agreements without getting anything in writing first for us to review. And that happens, that's a regular course of business here. I personally, future purposes, would like for us to address that in a process, so that we have a policy that states that we will not vote on legal agreements until we as a board have had the opportunity to review them.
You've been heard.
Okay, thank you.
So, do we move
Second.
on?
Second, with respect to the movement or lack of movement on the southeast quadrant needs in Del Valley, which would include Elroy, Del Valley proper, and East Del Valley. They have been asking us for a long time to please give them something. And it's been very frustrating, not only to them, but to me as a board member, to see other things move ahead of them and get acted on and bought land on, and we're already doing stuff, and we still have yet to move on anything in Del Valley. But to the School of Nursing, and this is to you, Dr. Morgan, I'd like for you to tell me whether or not the adults that you're seeing there will be MAP patient adults, or will they be other adults?
We will see MAP patient adults.
And others?
And other adults.
Is there are you all amenable, and I'm just asking whether this is a possibility, is anybody amenable to saying that that we're investing in this facility because you're seeing the majority of the MAP adults in that location or not? Is it possible to put a percentage in there? Just so that we know that there will be adult MAP patients, our patients, being seen there, especially since you did state that you're going to move the children's clinic off the Del Valley ISD site to this site, So then it's like, are we building this to accommodate the children that were being serviced or provided services to at this site? I'm just wanting to make sure that we are very clear on why we are investing in this. We're investing in this because the community was upset that it didn't have access to, the adults didn't have access to services. Now, the children who go to Del Valley schools or live in the area do. Is that the way it is, or only Del Valley ISD students are able to be seen?
That is a great question and a very good point. And I would, right now, on our campus now for children, we see all the children that come to the clinic. We don't turn anyone away regardless of where they come from. And so the plan for the new clinic, and the reason that we were moving the book of business to the new clinic is twofold. To operate a business, two businesses is a lot more expensive than operating one. So to already move established clientele who have adult family members, that allows us to, of course, keep the family in one spot. To the point, which is a valid point, about if you move all the children and then is there space for MAP patients or any other adults? I understand that concern, and we are ready to bring other providers in faster if needed if we max out, and that gets back to that max out period. So if I see 17 people a day and someone calls for an appointment and they can't get in within a 72-hour window because we are maxed out, which that is a challenge that, there's a timeline, and then it's time for us to bring another person on, because that's and I think that is in the agreement about within a 72-hour time frame. If people can't meet that need, it's time for us to bring another provider on and start expanding so we have more capacity. So that answers that question. As far as the ability to restrict our clientele to only MAP people or Travis County people, our goal is to see whoever, just as our philosophy is now. So it's hard to give a percentage of MAP patients, and here's why. People get the choice to where they go, and they get the choice to show up to their appointment or not. And so what I don't want to do is make a promise that yes, this % of MAP patients will be seen when I do not have full control over the entire population. And part of what is known, how much of the unmet need is still out there. I think we do have some numbers, but the question is, we might find a lot more need than what we even anticipate.
That's what I'm believing, but getting back specifically to the numbers, and for the development or the data, which will show what the community health need is out there. Community Care did the health needs assessment, and specifically for the Travis County and entirety population. So with respect to that, we would already have some kind of a foundation upon which to determine what kinds of services might be needed in that area. Is that not correct?
That is correct, and part of our services for what we've established for the clinic was based on that.
So would you be are you all wanting to do an additional survey, or I'm just trying to understand why you all would be doing something when we already had that information?
Why would we be doing something, you mean right now with the grant we were funded, are you talking about? So our focus grant now that we just received is from an organization to allow us to look at the social determinant needs, more of the non-met healthcare needs, which that's a grassroots effort going, boots on the ground in households.
But
So
is that going to be occurring out of this clinic or not?
that is going to be, it's going to start right now, and the goal is to inform services of the new clinic that we either can provide on site some of those unmet needs through social service efforts, or make sure we have connections to other community partners to help us identify resources to fully support the patient.
So what we would be paying for is actually the needs of our population,
Yes, you would be paying for the needs of your population.
not something else
You would,
that will be grant funded to provide those services.
yes, grants will always be hopefully a part of my world.
Okay, so all that will be, and the data will be kept separately, the numbers will be kept separately so that we won't have a problem, and it would facilitate the audit.
We will be able to stratify all of that information, absolutely, yes.
With respect to cost, have you done a prospective cost analysis to tell us what the cost would be so that we would know whether or not it would be more or less than what we're paying for through with the other providers? I don't know if anybody had looked at
What I
that.
was asking.
Yes, there was quite a bit of pro forma work that was done, both when we were looking at trying to partner this up under an FQHC model, as well as just a standalone advanced practitioner model. And I don't remember the more recent numbers off the top of my head and how you had it structured per encounter or per provider, but that can certainly be provided to the board.
Well, if we're expected to take actions today, it won't be provided to us today, but I would like to see that, and for future reference, whenever we are getting to the point of having to approve an agreement, those kinds of things we should already know those things. Not after, in Spanish, as we would say, después de tole, it would be beforehand, not after, for proposed costs. That's just my thought on the
So-
subject.
But to make sure I understand you, what you're saying is that it's the will of the board that you would see provider pro formas at each one of the sites?
Well, it would be a good idea for us as a central health to have a process, a streamlined process that's the same for whatever we do with respect to entering into any kind of agreement with respect to the provision of services, a clinic or whatever. We may not have the same clinic with the same services provided on each site, but we should go through the process of analyzing the need for services and the costs. Because if we know what our MAP population is, what we're paying for with our MAP population, then we should be able to know, kind of have an idea as to what the cost then would be for the provision of services at a particular site.
And we can certainly do that because there was a lot of hours that was put in, not just by Dr. Morgan, but John Morgan, you and your team, you spent a lot of time working on those pro formas, and there were many, many different versions and scenarios that we ran. So but the reason I'm asking if it's the intent, because that'll change up what we do here, because not all providers are going to want to provide that, because that is competitive information to some extent, and we'll have to figure out how to have that in closed session, but we do have that information in great detail.
I appreciate that, and
Yeah.
so I do have other questions, but in the interest of time, I'd like to know if you would entertain a motion. I know that,
Well, I'm gonna ask Dr. Bell and Dr. Zuniga if they have questions, because, and then to respect your request, I'm gonna give everybody a chance to speak.
yes, sir. Thank you.
Dr. Bell, you have any questions?
I have no questions.
Manager Zuniga, any questions? Hold on,
I-
Manager, Vice Chair.
I just have one follow-up because Manager Valadez was really asking what I had asked, but I think in a different way when I asked my question about the cost-benefit analysis, okay? And with that question, I was asking about our patients, right? That's what I was asking about. When we're putting in the money for the capital cost, which we are, then is this reasonable, this cost, vis-a-vis the number of patients? And I understand startup and ramp up, certainly, but vis-a-vis the number of our patients who are going to be seen annually, and how would that compare with elsewhere? I haven't heard the answer to that, because I understand, certainly, it's all, you're a clinic and you're transferring over the children and it's all takers, but again, we have certain obligation to our particular population of patients, and we have this capital that we're putting in, the money we're putting in for the capital construction, and I need to have some way to judge
Costs.
the cost benefit per the number of our patients who would be seen annually.
So, if I may, and Mike or Larry, you may want to jump in. When we went through the due diligence process for the ground lease, I thought that there was a payer mix estimate that
That's what
MAP
I'm
would
asking.
be something like 33% of the payer mix. Is that?
Deferred.
I'm thinking, I'm trying to remember off the top of my head, it's been a while since we've touched that document. But it was broken up with MAP, but we also had then broke out what is now referred to as MAP Basic. We called it the sliding scale population. So that also was considered part of the MAP. So
Right.
that brought it up a little higher, and I would have to pull that information to look. But most of the population was covered. It was more of the folks that would be in the MAP patient arena. And then, of course, we do have the children of those who at some point turn into MAP patients perhaps as they got older. But I would have to look at that specifically, but we had it broken down into, you are correct, the different payer mixes, what we projected.
And I will say this, that the comparison with other like facilities gets easier after you get started, and you can actually compare that to what you have out in the market at any given time.
I,
But I will say as a general rule, compared to an FQHC model, this has a higher cost per encounter compared to an FQHC
Right.
model, because you're not bringing in the Medicaid
I
match.
completely understand that. I'm just trying to figure out how many of those encounters are our patients
Right.
on an annual basis, for
So
instance.
if you were to, well, let's go back to the previous discussion, Mr. Chairman.
Please.
So if you have, I mean, what would a conservative estimate on MAP patients be?
For
Let's just say
number,
per week, and then we
Right.
can extrapolate that out.
well, I guess the best way to ask this question, and as far as if, and it doesn't give you an answer tonight, but in regards to where community care is right now, and they're open 3 days a week, and what percentage of those patients are MAP patients versus children, because I know there are varied. And then I think they capped out at they maxed capacity at 6 months and opened another day. So that's any indication of, what that would be. It would be very hard for me to expect to say if we had, if the percentage of the MAP population and the sliding scale population in that community was somewhere between, 50 to 60% of the community, if you look at the age bracket of people between, the 21 to 64, which would be a lot of that population. The question is how, to come up with a number of what percentage of those patients would come to the clinic and then come to the clinic regularly. I guess the best way to look at that would to see what kind of numbers does community care have right now in what they're running there out at the jail, the 3-day community. They're there for
Travis
3
County
days.
employees.
Travis
Yes,
County
thank you very
employees.
much. So, I can't recall specifically what numbers we had put in there. We did counters at 2.5 encounters per patient. And all I can say is I remember as we ramped it up over a 5 to 6 month period.
Right, and I think to answer Manager Greenberg's question and satisfy this with me, obviously you'll need to go back and see what of the pro forma detail can be provided.
Yes.
And then if we need to get NDAs set up, we could certainly, and these are documents that we look at the management level all the time.
Sure.
But if we can find a way to circulate that to the board, I think that might be one way to do that. But I
Yep.
don't want to get out ahead of your processes
No.
that you have to go through to get those pro
Yeah.
formas released.
And just
Yeah.
to clarify, that was one of the reasons that I asked, whether or not in this agreement, there was going to be a percentage in there of MAP and MAP basic that would be covered. But, I would like to make a motion.
Manager Most, I did have one more question.
First of all, I know the community had asked for this in the past, and I'm glad that we're expanding services. Maybe this may have not been the idealistic plan for us, and I want to commend you, Dr. Morgan, your staff, Holly, and Central Health, everyone who worked on this, and including our CEO, Mr. Giesland. I just wanted, for clarity reasons, that Central Health will not have control either on building structure or based on section 1.36, clinic hours. That is not, we will not have control, but I ask, hopefully, that your clinic hours complement our current hours in the Travis County with community care. At least you're not overlapping hours there. That gives our community additional hours of services that are hopefully available for them as needed. And thank you.
Can I comment to that? Let me just say thank you very much, because I will say that the one thing I can say is the partnership and working together as a team. And of course, as Mr. Giesling has said, and of course working with Jonathan and Larry and the Community Care Collaborative team, it has been a very good partnership in regards to working through some of the numbers and the resources that they've provided, so we can make sure we're not missing some things and we're all looking at it together. So I'm quite confident going forward that we would continue to work together and figure out how do we do the best collectively Because it doesn't do good if one clinic is out in the space. We are working together as a team, and it takes all of us to complement and work together. And I think that that fostered spirit would continue, and actually, continue to, we need each other as we go.
Absolutely,
So,
collaboration is the key.
correct. So I would say that, yes, there would be some hours that would overlap because we would be open during the day. But to extend in the evenings and on the weekends and other things, correct. We would continue to work together.
Much appreciated, Dave.
Thank you.
Thank you.
Andrew, any questions? If not, I'll take the floor.
Holly, can I vote?
You cannot vote, so both you and Sherry must abstain.
Accusing myself.
So I'll take the floor next. Dr. Morgan, thank you for stepping up and answering these questions. We really appreciate it. I believe in the project, so thank you.
Thank you.
Manager Bell, I thank you for correcting me. I stepped out of order, Robert's Rules of Order. I should have had a motion first. You're correct. So with that, will you make the motion?
I move that the board authorize execution of an interlocal cooperation agreement between Central Health, the University of Texas at Austin, and the Travis County Emergency Services District 11 in the amount not to exceed 1.150, or $1,150,000 to establish a health care clinic in southeast Travis County.
Second.
Okay, so I have a motion by Manager Bell, seconded by Manager Valdez. Do I see any questions, any further questions? Seeing none, we're gonna vote. You wanna do a hand motion or just voice, Michelle Holly? Okay. All in favor, say aye. Aye. All against? Any abstentions?
Aye.
Okay, so we'll have the record show that Manager Zuniga and Manager Greenberg are abstaining. Motion passes. Thank you, Dr. Morgan.
Thank you.
Thank you.
Can I ask one clarifying question after this? I mean, right now?
On this agenda item?
Yes, and that's because Chief Bailey was not present. Is there going to be a subsequent discussion? Are they going to have to agree to this, and then how does that end up?
Yeah, you
Interlocal
are.
agreement, the governing body of each governmental entity must approve. I don't know that the University of Texas has approved yet. I think we may be the first party to approve.
Good, just let us know. Thank you.
Thank you, Manager Valdez. All right, agenda items 1, 2, and 3 will be taken up together. These items are, for number 1, receive and discuss a presentation on the proposed Central Health and Community Care Collaborative fiscal year 2020 budgets, including fiscal year 2019 end-of-year estimates and ongoing budget strategies. It's an informational item. Mr. Canola and Lisa Owens will be presenting. Agenda item 2, discuss and take appropriate action on Central Health proposed fiscal year maximum property tax rate. Again, this will be an action item and will require a roll call vote. So Brianna Yanes will help us with that. And then agenda item 3, set a date, time, and location of the public hearings at which the Central Health Board of Managers will present and receive comments from the public on the proposed fiscal year 2020 tax rate. That also will be an action item. All right, Mr. Nuttall, Ms. Owens, thank you for coming.
Thank you. I'll kick it off and turn it over to Lisa. Thank you for bringing up those 3 items. This is another meeting where we're going through our fiscal year 2020 proposed budget. We met last week, had a briefing since that. We have had a community conversation around our fiscal year 2020 budget Monday night. And yesterday, excuse me, we presented to the Travis County Commissioners Court. We presented our proposed budget. So we've had a couple of additional meetings in between the last board meeting and this meeting. So as the chair mentioned, we are requesting action on a couple of items, 2 of the 3 items. The first item we're requesting action on is setting the maximum tax rate, which is a roll call vote. This simply sets the maximum tax rate for the budget. It does not have, really the only requirement is that the rate that you set in the approved budget does not exceed the maximum rate that you set in this action. So it kind of sets a ceiling as it relates to where you can end up overall on your tax rate in the budget approval process. And then secondly is setting the public hearings. I know we've said, we've talked a little bit about the certified tax roll coming in a little bit late. It did come in recently. It was about a month late, so we're trying to work in all the meetings and the required public hearings through the truth and taxation process. But it looks like we will, again, as we've talked about, eventually be approving our budget and then in a subsequent meeting, approving the central health property tax rate for fiscal year 2020, both here at Central Health and at Travis County. So as it relates to our fiscal year 2020 proposed tax rate, we're proposing an overall tax rate of 10.5573 cents. That rate, so we look at that rate a couple different ways. Traditionally, we've always looked at our rate as a percentage of what's called the no new revenue rate. So we looked at it traditionally from the maintenance and operation or the M&O side of it. It's 6.9% over that M&O portion of the rate, which you see down on the left is the majority of our tax rate. Overall, when you combine the debt service rate, we're at 6.84 cents over the no new revenue rate. And then on the right, you see just on the average taxable homestead value that based on the new tax rate, the average taxable homestead value would see an annual increase of $23.07. And then just as a reminder, we have our homestead exemption, which is the maximum amount allowed by law, state law, which is 20%. And then over 65 homestead exemptions and disability exemptions of $85,500. Excuse me. Our taxpayer impact statement, we've looked at homestead values over bands, starting at $150,000, going up to $550,000, so $100,000 increments. We've calculated the homestead exemption amount, and then the Travis Central Appraisal District was able to give us bands of value increases by the bands of value that we've calculated. And so you see the bands range from anywhere from a low of $9 per year to $26 at the maximum value, with a percentage increase anywhere between 5 and 7%. So the next chart, this is a forecasting tool that we use for our budget. Typically, we do a 5-year forecast, but we've extended it out to 7 years this year just to look at long-term implications of known events that would happen, known financial events that would happen during this period, and what the impact of a tax rate would be over those years. As we look at the forecast, we're mindful of a few things on the chart, primarily our reserve levels and our days of cash on hand. And as it relates to financial metrics that we look at, we'd always want to look at days of cash on hand being around 100 days, or we see a trend that if we dip below that, that there's a trend where we are reestablishing that rate over time. And so you see at the 6.9% rate that beginning in fiscal year '20, we fall below that rate, and we reach a low point in fiscal year '23. But then beginning after fiscal year '23, the days of cash on hand begins to increase. And then in fiscal year '26, or actually fiscal year '24, we start looking at, are we structurally balanced, or if our reserves are low, do we have more sources than uses, and are we building up our reserves? And so in fiscal year '24, you see our sources are greater than our uses, and we start building up our reserve levels and our days of cash on hand, which correlate with each other. So just as a reminder, we prepared the initial proposed budget at 6.3%. Our last meeting, we proposed a tax rate of 6.9% over effective, and that's the rate that we presented yesterday at the Travis County Commissioners Court. So I'm going to turn it over to Lisa to go through some of the detail on the fiscal year 2020 proposed budget.
So this slide just highlights for you the change that has been made since the last time we talked through this, last Wednesday. And the only change that we did make was increasing the revenue from the property taxes as a source of funds by $1.2 million when we made that change from the 6.3 to the 6.9 over the no new revenue rate. And then also in your packet, we've included attachment A, which has the highlights of the sources. And when we get to the end of this process, these are the documents that we'll look at. So we're going to be presenting in that format as we go forward. But again, these are still proposed numbers. So the sources total $290,800,000 at that rate that was discussed. And then the uses the same. And $278 million is in healthcare delivery. And our attachment B, which is the next two pages of the presentation, go through in detail comparing year over year, so you have those details available for your reference. So again, 96.4% of the uses of funds do go to healthcare delivery, and about just over $12 million in administrative and tax collection. We've also included, with no changes from our last presentation, a draft of the proposed budget for the CCC, which we will include in the process when we go to adopt the final budget. And so there have been no changes to that since our last meeting. Total sources of funds, $66.2 million, and uses the same. And many of the expenses in there are for the continued healthcare delivery in some areas, as well as the Desert project costs and the UT affiliation agreement. And again, uses of funds being $66.2 million. And finally, just what is next tonight, we do need to vote on the maximum tax rate, which starts the truth in taxation process. We then have our two public hearings and would come back on the 18th and ask for approval of the budget. We would go to the Commissioners Court to adopt our budget on the 24th. And again, because of the timing, we would come back on the 25th to get the tax rate approved, and then return to the Commissioners Court on October 1st for that tax rate approval. So a two-step process this year, but just a few more meetings. Just a few more as we head into September. So we're happy to answer any questions.
Let's get a motion on the floor first. Manager Bell?
I move that the board approve a proposed tax rate increase of 6.9% above the no new revenue tax rate for the 2019 tax year, which will support Central Health's fiscal year 2020 budget. And I further move that the required public hearings on such proposed tax revenue increase be held on Wednesday, September the 11th, 2019, at 5:30 p.m., and Wednesday, September the 18th, 2019, at 5:30 p.m. at Central Health's Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702.
Second.
Okay, so I have a motion on the floor by Manager Bell, seconded by Manager Valdez. Any questions? Were you had a question, Mariah?
I was gonna second it.
Go ahead.
I just want to make a comment.
Manager Valdez?
I want to thank y'all for all the work that you've done, and I want to thank this board for looking at a rate higher than 6.3%. I personally was going to advocate for 8% because I didn't know what the legislature was going to come back and do during the next session, and that's still my preference. But in looking at the forecast, it looks like we'll have a relatively healthy days of cash on hand, which I know is what you all were looking at. And it looks like we'll also have a healthy reserve line for the years ahead, and I'm really happy about that. So, but I just wanted to tell you all, I'm still an 8%er, but I will support the 6.9.
Manager Greenberg?
So, Manager Valdez, I certainly understand your concerns. I completely understand your concerns, but I do think that this is a rate that allows us to provide the care to our growing population of need here in Travis County and be mindful of our fiduciary duty to have stability in our finances. And I want also to thank all the staff, including many who are not here, and board and everybody else. Thank you.
Manager Bruns?
Yeah, just one question, Ken, I think I asked it last time. The budget becomes effective October the 1st, is that correct?
Yes.
And Travis County Commissioners Court will approve our rate on that same day.
That's correct.
So is there any issue with that?
The rate has to be approved by October 18th, but our budget needs to be approved by September 30th. So I think
So there's not a problem
No.
with this timeframe, is it? This is what I'm saying. My only other comment, I agree with my colleague, Manager Valdez. I really think that at some point we need to, given that we're in Texas, look at the ability of counties to be able to address the health needs of our community. And if the state's not gonna do it, we might need to look at how do we become more proactive in doing that. And so I will support this, but I'm really concerned that our other colleagues, the city and other county government doesn't have the opportunity to do things, so we might have to step in, and that should be something we might to consider as we go forward. So that's my comment.
Manager Mosaic?
Thank you, Chair. Thank you, Lisa. Thank you, Jeff, for this. It's truly humbling to note the work that we're doing at this low, small tax rate compared to other hospital districts here in Texas. I understand we had a lot of thought and process as a board and staff with this tax rate. And I personally feel comfortable with this tax rate, given that we have not been capped as other entities, and we'll be able to deliver on our promise and expand our services to further our mission. And we have added additional revenue from the downtown campus that hopefully will generate additional revenue to fill our mission. And knowing that some of the reason actually we also anticipated this tax rate, we're going to be losing additional funding in the long run with district winding down and having to replace it. So I think that with that, again, I feel very comfortable with this rate, and I commend you on this efforts, and I look forward for us for a new year and to provide services that is much needed for our community. Thank you.
Manager Zuniga, any questions? Manager Bell?
Yes.
Manager Greenberg? Well, I'm gonna take the last one, and I agree with Manager Jones, Manager Valdez, Manager Greenberg. I would like to see it at 8% as well, because we don't know what's gonna happen in a couple of years, and we don't know what other government agencies are gonna ask us to do in the future as far as services, so. But we're good, this is good, I'll go with that. All right. We have a motion on the We have a motion by Manager Bell, seconded by Manager Valdez. Ms. Brianna Yanes will now assist me in taking a roll call vote. For the roll call vote, Ms. Brianna Yanes will call the name of each board member in attendance in alphabetical order. Each board member must, when his or her name is called, answer yay, nay, or abstain. Brianna.
Treasurer Charles Bell.
Yay.
Vice Chair Sherry Greenberg.
Yay.
Manager Shannon Jones.
Yay.
Manager Maram Musaitif.
Yay.
Manager Cynthia Valadez.
Yay.
Chair Guadalupe Zamora.
Yay.
Manager Julie Zuniga.
Yay.
Thank you.
Yeah,
All right.
I caught that.
We're going to go on to the consent agenda items. C1, receive the July 2019 investment report and ratify Central Health investments for July 2019. This is an action item. Manager Valdez.
I move approval of consent agenda item C1.
Second.
So I have a motion by Manager Valdez, seconded by Manager Bell. Any questions? Seeing none, all in favor say aye.
Aye.
All against? Any abstentions? Motion passes. And I forgot to say the motion passed on the previous one, Council, I'm sorry.
Okay, still passed.
Okay. All right, agenda item 5, receive and discuss the report of the July 2019 financial statements for the Community Care Collaborative. It's an informational item, and Ms. Lisa Owens will be presenting. I'll remind the board that Manager Jones has requested that we limit this discussion to 15 minutes. This one we're going to just limit.
Okay, well, we're presenting July 31st financial statements. So just a couple more months in the fiscal year. We are in a cash position at July 31st of $73 million. And total liabilities of $51 million, with total net assets at the end of July of $22 million. And we are in August now, and so some things did happen since then. The variance in the cash being the timing of the UT Dell Medical School affiliation agreement, and that was made in August. So you'll see that in the August financials. So total assets as of July 31st are majority cash, and that is $73.5 million. Liabilities, $49.6 million. That does include accrual for the UT affiliation agreement payment of $35 million, and the remainder being mostly in provider accruals for payments for provider services that have not been paid yet. Total liabilities at the end of July were $51.2 million, and net assets at $22 million. Again, total liabilities and net assets at $74.5 million. DSRIP revenue year-to-date is at $76 million. We did receive in July final revenue from earlier reporting for DSRIP, and the timing on that did put us over budget with the reporting, but that $76 million is what we anticipate through the end of the year. So $76.5 million in DSRIP revenue, member payments totaling just over $45 million, and then other sources, which is predominantly interest, of just over $500,000 for total sources of funds through the end of July at $127.5 million. Our healthcare delivery is at about 70% of our total budget at $66.6 million, and I'll go into more detail on the next slides on that. And then we did accrue for the UT services agreement at $35 million, and our estimated DSRIP project costs for the projects that are being delivered in the DSRIP program, $8.5 million. So looking at a little more detail on the healthcare delivery, we are at just about 73% of our year-to-date for primary care at $38.2 million, and we have additional slides for primary care and specialty care. And then specialty behavioral health, a little ahead, but keep in mind that the AISD school health program that was approved by this board is in that, and so that is anticipated to be over budget and is planned to be over budget by just that amount. Specialty dental care at about 53%, and our post-acute care, you'll notice the asterisk, that budget was adjusted. We are just at 82% through July of this year. Otherwise, healthcare operations, we have a little more information. We have been tracking at just 60% through this point in the year, and then our total healthcare delivery, as I mentioned, at 70% of the budget. So our primary care, more details here. We do have about 75% of our estimated expenses for our largest contract with Community Care. We've talked about in months past that we'll start to see the expenses for El Buen Samaritano's contract slow down, and we are closely monitoring the Lone Star contract as those services are being delivered through that contract now. And I've also mentioned in the past that People's Community Clinic is year over year, more of the payments have been pushed to incentive payments, which will be at the end of the contract year, so that's you might see a timing difference there if you look at the prior year. Our total primary care as of July 31st is at $38.2 million. On specialty care, I think we have talked about the highlights that I have in the past, but we do not anticipate consultation services having any more expenses, although we are in the final negotiations, which we've talked about for an e-consult software. And we are going to be over and under budget in some of our specialty, especially some of the specialty that we budgeted for with community care, where we shifted from just one line item for specialty care to more specific specialties. So we had better data in our financial statements, but we are closely monitoring that, as well as adding new programs. And I think you've heard about this last month from John, but we did begin to offer some general surgery. So we have our first expenses estimated for general surgery, which is exciting. And then I did hear that a contract was executed for physical medicine and rehabilitation, so we should start to see services there as those newer programs get lifted up. So total specialty care through this time in the year is at $5.4 million. And then finally, our healthcare delivery operations. These are the departments that support the healthcare delivery, and all on track. Underneath that, we are 83% of the way through the year. Total combined is at 60% of the year, and we anticipate being under budget by the end of the year, but at $6.8 million through July 31st. So with that, I'll answer any questions.
Andrew Greenberg?
I'm certainly delighted to see the increase in some of these specialty areas, and I know that is, delivering care is first and foremost on our minds, whether it's specialty or it's primary and to our target population. So I appreciate that, and I know efforts are underway to ramp those up even more, and seeing the general surgery. I have a question. Cataract. I know that there was a change a couple of years ago to where that is now done in the standard outpatient, as other entities have been doing for some time. Where is that reflected in here? Do we know?
Morgan?
I'm gonna not guess, and I'm gonna ask John Morgan to join me.
I saw him making his way.
Good evening.
Slowly.
If I could just, I'd make this go back. It is not going back. So those are, we have several different contracts for ambulatory surgery centers. But last year, when we prepared the budget for FY19, we grouped our services by specialty care service line.
Exactly.
So the ophthalmology line, that's part of the reason why that particular line is as high as it is at
That's what I thought.
1.7 million, as it includes those surgical costs.
Okay, that was my assumption,
Yes,
but I
ma'am.
just wanted to confirm that.
It-
Thank
It's
you.
also the share of other facility costs like anesthesia that are related
Right.
to those procedures.
Yes. All right, thank you.
Yes, ma'am.
Any other questions? Okay. Manager Jones?
I just have a question, maybe somewhat of a, I don't see actual numbers of individual encounters per these. Is there any way we could get that, or perhaps it's there and I'm missing it, so is that available?
Absolutely available. We have encounters and patients served for every one of these lines. It's a lot of data. So
Yeah.
if there's a particular area you're interested in, we can certainly provide that, or I'm happy to follow up with you offline to make sure we
Yeah, let's follow up
answer your
on it,
question.
because I don't want you to put you into any unnecessary.
That's actually data that I would like too, so.
I think that we should all get that.
I asked first.
And I support you, Sharon. You know, but we're all equal at this
I'm
time.
just joking with you.
You can forward it. No, you can't.
No, that's right.
Cannot. That was a joke.
Another joke.
Yeah, yes, Manager Rondes.
Thank you, Shannon, for reading my mind. And I think that goes to when I was asking about the cost for if we were going to have future clinics and provide different services, lines of service of different providers. We had that cost to be able to know, get some feel for, as we're auditing someone else providing the service, is it equal to what we're able to do under our enterprise? With, under the CCC, with community care, Central Health. That's always good information for us to have. Now, I'm going to wait for the public hearing.
Any other questions? Seeing none, this is an informational item only. Thank you, John, thank you, Lisa.
Thank you.
All right. Agenda item 6, receive and discuss a report of the July 2019 financial statements for Central Health. Informational item only. Ms. Lisa Ola.
Hillary died. Oh, it's back. Just buzzed. Okay, I will just hit the highlights. We are in the middle of the summer, so our tax collection is very low, and we had previously collected the majority of our tax revenue at 99%, and our intergovernmental transfers year-to-date were at $117 million. So looking at the assets, we did have $116 million in current assets, which is mostly cash and short-term investments. Our non-current assets includes our Sendero paid-in capital and debenture, and that total is $118 million. And then our capital assets, less depreciation, is $113 million. Total assets of $349 million as of July 31st. Total liabilities, we have very low current liabilities. Those are liabilities due within, estimated to be due within 1 year, at just $6.4 million, and non-current liabilities, $8.5 million. So total liabilities, just under $15 million, which leaves our net assets at $333 million. And again, total liabilities and net assets at $348.8 million. So through July 31st, we have collected sources of funds of $265 million. And in the month of July, $1.4 million, which included, again, just a small amount of tax revenue, our lease revenue, and then other revenue, which is predominantly interest. Our healthcare delivery expenses were $27.9 million. I mentioned in the CCC presentation the DSRIP revenue was received. The DSRIP IGT was also made by Central Health, so we'll have more detail on that on the next slide. And then our administrative programs, just under $500,000 for the month, and just at $5.2 million for the year. So we are at 57% of our budgeted expenses. So our total uses for the year at $187.8 million, and our excess sources over uses puts us at $77.4 million year to date. A little more information about the healthcare delivery. We've broken this up into 2 slides, and so first we have the IGT, the
intergovernmental transfers for the DISRIP program, you'll see there. And primary costs, you do see a negative there. That is just a one-time adjustment, reclassification. As you know, we started a sexual and reproductive health program, which is down in our service expansion funds, and we expanded those services, and we just had to reclassify from one line to the other this month. But the year-to-date numbers are up to date. So our total provider costs year-to-date at $25.2 million, and our total service expansion funds, which is all in the sexual and reproductive health, is at $583,000. Looking at our healthcare delivery operating costs, we are at just under $5.4 million year-to-date, and about $585,000 for the month. Again, just at 56% of our budgeted expenses. And then other campus redevelopment, we are starting to see more expenses there as the abatement and CEC utilities are actively project costs. We have active project costs there. And then our ACA enrollment and subsidy includes both of our programs, the CHAP program as well as the ACA high-risk program with Sendero. So total other costs there at $790,000. Excuse me. Total healthcare delivery, $27.9 million for the month of July. And again, happy to answer any questions.
Andrew Valdez.
I really only have one for right now, and that was for clarification on the, I'm assuming it's the ACA enrollment subsidy?
Yes.
And with respect to the HAM contract,
Mm-hmm.
HAM SIMS, whatever, the prepayment, is there a way for us to look at, or to get the information with respect to the breakdown and the demographics of those getting enrolled?
Excuse me.
I'm sorry, I was looking at another piece of information. Could you ask me that again? My apologies.
Yeah, that's okay. The enrollment, the musicians that we're paying the premiums for, is it possible to get a breakdown of the demographic of who is getting signed up and who is not?
So demographic as pertains
For
to
the
race,
enrollees.
ethnicity, gender,
Yes.
et cetera.
And I have a reason for asking that, and I'd just like for it to be borne out once we get the data. And I can bring it up later, I can bring it up now.
So I'll have to check, first of all, I'll have to see what we collect and what we don't collect, with respect to Hammond Sims. But I think that, once it gets on the insurance side, they don't collect race and ethnicity data because they can't. Let me figure out what we know on our side of the equation.
On the front end.
Yes, ma'am.
Could you add to that zip code data if it's available?
Yes. Yes. And my reason is to make sure that we're actually reaching the entire demographic, maybe not necessarily, but not all, one particular race or ethnicity or gender
Or section of town?
or sex.
Thank you.
Thank you.
Any other questions, managers? Seeing none, this is an informational item. Thank you, Lisa.
Thank you.
Agenda item 8, receive and discuss an update regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory action. Again, it's an informational item, and Wes Durkowski is going to help us with that. What's that?
5-minute break.
Sure. Okay. Let's take a 5-minute recess, if it's okay with everyone.
And
All right, so we're gonna come back into session. It is 7:20. We're gonna discuss agenda item 6. We need to read it again, Holly? Sorry, 8. Agenda item 8, receive and discuss an update regarding Sendero Health Plans, Inc., including the effects of federal legislative and regulatory actions. This is an informational item, and I'll remind the managers that we're limiting this discussion to 15 minutes. Wes?
Thanks for having us. Sendero, we're happy to be back and continue our discussions. Just a few brief slides for this evening. The first is a quick recap just of our financials. We file quarterly financials with Texas Department of Insurance. These are public information as of a week or two ago. I'm on slide 2 of the slides, page 2 of the slides. From those financials, maybe the main interesting points are that we've delivered over $31 million in services to an average of 14,000, just over 14,000 members over the past 6 months. During that period, we reported a net income of $1.5 million. That net income reflects a plus $2 million development, which was a release from funds we had previously booked in 2018. So our kind of restated net income for Q1 and Q2 is actually a slight loss of just over $400,000. That loss is in line with the actuary projections, which we discussed at the last meeting, I believe, in closed session. In terms of surplus, we're still projected to end the year. We currently have $14.9 million. We're still projected to end the year with sufficient surplus to go forward. The next slide. Just to share some information on the CHAP program. We thought about what we could be happy to share publicly, and we probably thought about the biggest impact of the CHAP program, and that is services for the members. So in this case, these are all formerly uninsured members. In this map, you can see by zip code where those services are being delivered. This map represents a total of approximately maybe $7 million in services that were delivered through June by zip code. So the scale is roughly zip codes that are in red have each received more than 250, each zip code received over $250,000 in services. Orange, the few orange zip codes are $100,000 plus. Yellow is 50, and the greens are around $10,000 plus per zip code. There was a great deal of variation across the zip codes. Of course, the brighter the color in the red, the more services were delivered. The highest zip code, not to name names, but was one of those red zip codes, represented just over 1.3 million in services. 1.3 million services for one zip code is approximately close to the entire premiums that Central Health paid for the CHAP program for 6 months. So another way to say it is that for the funds that would have covered just one zip code in services for the first 6 months, the risk adjustment in the CHAP program kicked in to provide services to all the other zip codes listed. So it was a very highly leveraged program. We're very happy about the way this is playing out. And of course, these counties and zip codes, Travis County, these zip codes are right in line with the priority for Central Health's missions and services to the community. With that, we'll go to the last slide. So just as a reminder, we can state that from the actuarial reviews, we had 2 sets of actuaries reviewing our data to date. They reviewed 3 things: our 2019 progress, the CHAP program itself, and also plans for 2020 forward. They both agreed and concurred on 3 main points. The first is that Sendero is projected to end the year with sufficient capital to move forward. The second is that the CHAP program is working as intended. It is redirecting risk adjustment funds to local care. And the third is that increasing CHAP and membership improves projected income, allowing us to deliver more services. With that, we did have some discussions on the Sendero board, questions on the Sendero board about what we were thinking about for 2020, and the Sendero board voted unanimously to recommend to the Central Health Board to continue the CHAP Premium Assistance Program, targeting the 500 member level that was previously set in last year's budget. And with that, I'm happy to take any questions.
Well, I'll start off.
Sure.
Dr. Bell, thank you. Dr. Allison, thank you. Wes, thank you. Betty, thank you. Thanks. All right, Maram?
Thank you, Chair. Thank you, Les, and Sendero team, Dr. Allison, and I was
Betty?
Betty Patterson.
Betty.
In the background. So,
and here, Sendero's chair. So my question is actually related to the 223 enrollees that we enrolled. And in terms of utilizing the system, so how many of those, if you broke it down, utilized the Sendero's benefits? And do you have a breakdown of that?
I can share that the majority of them are utilizing benefits.
So when you
and
say majority, what's majority?
So
50-50, 60, like,
it probably depends on what level you want to put the cutoff at, but it's basically, oh yeah, no, I'm sure that at least 3/4 have utilized in some degree. They have all been outreach to. So remember back at the beginning, we did phone screenings, home visits, to try and give everybody screenings, health assessment screenings at the beginning. Follow-up it is kind of voluntary, up to the member. We work with them when we know they needed to come in for services, but if somebody's fine, it's a fine line. We're not going to harass anybody to come in and see the doctor.
no, I understand,
that-
given that the population that we outreached and enrolled into this program have a high risk ratio.
I know, definitely, yes.
And they are sick, and they haven't, some of them did not, based on what you just said, did not utilize the system. So in terms of cost, so coming up next year, those who did not utilize it are probably sicker, and they're gonna come back, and, so I'm just thinking about in terms of the
Yeah.
utilizers and taking advantage of the health plan and their cost of care. And so it's just a concern that I may have. And I'm glad things are moving forward and you're receiving capital and you're not asking us for anything at this moment in
We're really
time.
glad about that too.
I just wanted to see in terms of the health outcomes of these patients who did not utilize the system sufficiently.
So first off, overall, you could have seen, remember from the previous slide, there was a great deal of utilization across the board. And so for any population, and this is the way insurance always works, if you take a group of people and look at them a year later, some people who have gotten worse, some people who have stayed the same, some people who have gotten better. So there will always be some people who are low utilizers and high utilizers. So our concern, and that's one of the things the actuaries looked at, was for this pool that we selected, overall, did it fit what we expected? And even though there was greater pent-up demand than we expected, turns out to be, slightly higher reimbursement than expected, so it should balance out. So that leads to kind of maybe your question is, are we doing everything we can? And the short answer is yes. So when you look back and you say, remember this, we selected these 200 people, not by lottery, but last year we went back and based on everybody's best information, we said, over the next year, who is most likely to need care? And then based on that, we came out and it turned out that we selected a cohort that, needed a significant amount of care. It's like, can we improve upon that for next year? That would be a very high level actuary and clinical question. But from what we know today, we did very well at selecting overall a group that needed care.
And one last thing,
Yeah.
giving, I don't know in terms of the numbers and confidentiality issues, based on the population that our population, what have you noticed the biggest burden of disease amongst this population that could probably help us in the long run of more preventative care to address? So is cancer the number one for them? Is it other issues, diseases?
I'm happy to speak, for the non-clinical, what stood out to me was, one, kind of the level of comorbidities, but it was interesting to see the distribution of conditions kind of mirrored a high risk, or kind of mirrored the incidence of diseases in the population. So even in this small group of 200, we saw everything, so it was like everything, from cancers, cardio, down through strokes. It kind of followed like a pretty steady distribution of diseases. So we can come back some of the next times, I think, at some level, we'll come back and try and think about what we can share to kind of lay that out.
Because
'Cause it
I'm
was-
interested
yeah.
in terms of comorbidities and what conditions are, that we perhaps can work on, giving public health background that we have. So anyhow, thank you, appreciate it.
Sure, thanks.
Andrews? Andrew Jones?
I'd just like to acknowledge, I think it was about a year ago today, we were sitting here talking about your future, at least for our efforts. So the fact that you're still here a year later, I want to commend you on the work you've done.
Oh, no, okay, so right now, Sendero would like to commend every one of you. Like, we appreciate, this has been a very long, hard ride. But, it appears that we did, everyone did their best, and it worked out the way we had hoped, so we're happy to say
We appreciate the effort you make.
that. We appreciate all your support, definitely.
Just one question, as a demographic person, I'm looking at this map here, and in the center, this is 78742, and I noticed that quite often, it's like a dog, look like a dog leg. This area is I would imagine that this is an area that really should be outreach to, and I'm not sure if you know how to do that. This is the area over there, and I remind people, 183, 71, the river. It's isolated. A lot of construction has come over, and it's a very poor area. And a lot of people, we have a lot of morbidity and mortality. In fact, one of the highest in the county. I was wondering why there's nothing here.
We were kind of surprised about that too, but for whatever reason, it means that in that cohort of 200, this is just those 200. So for whatever reason, there was nobody in that neighborhood, but I'm sure this year, we'll make better efforts to make sure that there's an even distribution. But it's true, a lot of the zip codes, just do for whatever, because they're more industrial, or more rural, lower population, and so, or they were better off on the whole west side. You can see a lot of the zip codes, they're not labeled, but a lot of zip codes don't even show.
Well, that sort of sits as an outlier. Thanks very much. That was the only question.
Andrews, any other questions?
Just
Commander Ellis?
to commend you all again, as I'm sure we all are thinking. I'm very glad that we're here today, having this kind of conversation as opposed to telling you it's time for you to check out. So I'm very, very happy, and I want to thank this board for having taken a risk and supported them on this pilot program. But I think that what it's going to show is that with a little bit more, with a full enrollment period to address recruitment, because you didn't have it before. And having gone through the process and being able to improve upon the strategies that should be implemented in reaching out, I'm hoping that we'll see a much greater, or at least a greater, return of our investment for this upcoming year. And I just wanted to tell you that.
Thank you.
And I want to thank your team, and I want to thank this board.
Manager Executive?
Thank you. One last question. Does Sendero cover family planning?
As part of like the standard ACA benefits we do, and off the top of my head, I can't remember what else I'd want to say about that, but yes.
Okay, thank you.
Yes.
Anyone else? Manager Bell?
Oh, yeah.
All right, this is information item only. Thank you, Wes. Thank you, Betty. Thank you, Dr. Ellison.
Thank you.
Thank you, everyone. All right, agenda item 7, discuss the 1115 Medicaid waiver delivery system reform incentive payment district projects, community care collaborative, including healthcare delivery arrangements and other interrelated community partnerships. This will be presented with Jeff Knodel and Monica Crowley, and this will be presented in closed session. I announce that the board is convening in closed session to discuss agenda item 7 under Texas Government Code, section 551.085, governing board of certain health providers of healthcare services. Who are we keeping?
would you consider my
Right.
offer a chairman?
One second. The board is reconvening in open session. There will be no action not taken on item number 7. It is 8:17. I'm sorry, Manager Jones, what?
I was just asking from the last item, is it possible we could direct that to strategic planning to come up with, formulate some strategy to address what I had raised,
Sure.
the item I raised?
Will you be willing to take that, Vice Chair?
Yes, I will need staff to, we've got a kind of checklist that we keep for strategic planning, so we'll need to slot that in. I think the next meeting may already be filled up, the October, but we'll look at the one, but if not, we'll look at the one beyond that.
Good. Agenda item 11, receive and discuss a report from the President and CEO on Central Health operations and current activities, including A, the fiscal year 2019 strategic work plan and operational priorities, B, an assessment of systems and processes, and C, other personnel matters. This is an informational item only, and Mr. Gielen.
Members, we're currently going through a transition and driven in large part by the changes in the federal funding that we've talked about extensively and the consequential wind down of the CCC through the close of the district period. On October 1, Central Health staff that are currently assigned to the CCC, their name badges will still have their name on them, but it'll have the Central Health logo on it. And, you know, we're really thrilled about this because they're gonna come to work, and what they do on October 1 is gonna be the same as what they were doing when they left on September 30, but, you know, the reality is we're bringing two sides of the house together. So we have a series and a number of meetings internally. You know, people are still working together on projects across the enterprise, but we're coming together in enterprise level meetings in a way that we never had before. And so I'm really excited about the possibilities, I think, as we focus on how do we leverage the strengths of the enterprise. And it's not just Central Health, it's community care, it's Syndetto. And so I just wanted you to know that transition work is still occurring. Next month, I will bring to you an organizational chart and a business flow chart. And that's gonna be critical work for two reasons. I'm not sure which date, because the budget takes priority, and there may be other pressing matters, for example, the work with Ascension Seton. But we'll carve out enough time around where we can talk about this. You know, the organizational chart really is just so that you all can see. And the reason I'm not bringing it to you now is I've been working with executives and doing a lot of research in terms of what this looks like from an enterprise standpoint, and looking at what different companies that have subsidiary type relationships do to organize and work more efficiently. And so we've been working on this for quite some time. I know Stephanie's put a lot of hours into it, helping pull all this together. But we socialized it. I've been talking to individual executives, but we socialized it last week to the full executive team. I'm continuing to get feedback. Today, we socialized it in a group that I call the deputies meeting, which there's no executives allowed in the meeting. It's just their reports, and it's just myself and the deputies. And I use this as a sounding board group, but also as being more inclusive. I think it's important to reach those people that don't have executive in their title and that are up and coming leaders or just thought leaders, and bringing them into the fold on this. And so the next step is to start going around to different pods within the enterprise, some bigger groups, some smaller groups, but having some one-on-one conversations and answering a lot of questions. Anytime you have an organizational transition, there's a lot of apprehension around that. People want to know, is anything going to happen to me? Is my job going to change? Am I going to have to switch colors or staplers? Whatever it is that's important to them, we want to make sure that we're addressing that. So the second thing is the business flow chart, and this gets to, I think, some of the comments, Manager Valdez, that you were making. But right now, there's a lot of things that we do that they're born of ideas that are tossed at us, and there's some public expectations that are set. In fact, we talked about one tonight. And what I'd like to do, I want to go back to some comments that I made to the board in December, is we still want to be that convener where people can bring the ideas forward, but we're going to have to be a lot more disciplined in the business cases that we put together. In fact, recently, just back this morning, there's the opportunity to hire for a particular position, but really we realized we need to take a step back and figure out how we're gonna staff out this entire function rather than just posting for one position. And so having each executive that has a need either in staffing or wants to start a new program or wants to make operational improvements, they have to start putting together business cases and bringing them through a defined process, so that we can make sure that we're allocating human and financial capital in the most efficacious manner, but also making sure that all the business cases, if there's an economic consequence to this, as it relates to are we efficiently serving the people that we're privileged to serve, that we're doing so in the most cost-efficient manner. So as best we can, I'm trying to pull us back out of just, hey, what's the newest idea mode into, okay, let's be a lot more methodical in terms of how we go about making decisions in our planning. So I'll work through that business flow chart next month as well. And, real briefly, I want to talk, and lastly, I want to talk about some of the legal processes. Things get thrown at us quickly. And when we negotiate, and this gets to, why don't we have certain legal documents well in advance of some of the decision making? But especially when you're working with third parties, you are dependent upon sometimes you can put deadlines on them, but at the end of the day, there are always issues that come up that have to be negotiated, usually at the last minute. And we will continue to endeavor to try to get these agreements to you in as much time as we can. Tonight I made the decision, or for tonight I made the decision, yes, we could wait another couple of weeks, but I felt like the further we got into the budget process, the dicier that was gonna become. And so, I had to make the judgment call. I'm gonna bring it in front of the board, that we have. We have a number of executives that put their eyes on these sorts of documents. Holly spends a lot of hours with her team on these as well. And, when we present these things to you, understand a lot of people have looked at it and have opined on it, and I'll be upfront. A lot of executives will come to me saying, I really think this is not a good idea, and here's why. And we take that into consideration. But please understand that, management is looking at this at all levels, and when we bring something to you, we've tried to mitigate as much risk as possible, and extract as much value for our patients as we possibly can. So, I wanted to provide a little bit of context of that. We hear you. We would like to get these things in front of you. We'd love to give you 4 weeks advance notice, but just the way negotiations work doesn't always work out that way. But thank you for allowing me to just present these points tonight.
Manager McClintock?
We'll come back more next month.
Thank you, Chair. Thank you, Mike. Appreciate it. I was wondering if possible, we can, as a board, collectively release a statement to welcoming the new transition and supporting them in a way.
The new what, I'm sorry?
Sorry, you said
The
it
new
again?
transitions into Central Health.
You a staff member? What do you mean?
Absorbing CCC.
Oh,
I don't know if we're ready for that yet. I think there's gonna be
You
a
just mentioned
strategy.
October 1st.
Yeah, no, actually, I have something planned. I haven't
Yeah.
sprung it on people yet, but,
Yeah.
if you'll permit me to kind of do our thing.
Yeah.
But I do think it would be really nice if we could, have some folks, stop by the CCC offices and say, hey, we're glad we're all in the same house now. I think that would be a powerful
I am.
statement.
you want managers to do that?
I would-
Let me think through that, because there's something that I
But I would like
planned that I
something
need
for
to do to
us
staff a
Yeah.
little bit.
to do
Yes.
on
And-
that regard.
Yeah, let me think through
Yeah, I just didn't
how to
wanna-
sequence that.
Yeah, I just didn't want to get out ahead of you, is what I was
Yeah.
saying, Maram. But I am ecstatic about this, actually, that, we will all be together. I think it's going to be a big improvement in
Yes.
the organization, quite
Everybody's home
frankly.
now.
Yeah.
Manager Valdez?
And just further clarification, I appreciate what you were saying about, one of the concerns that I had. But I'm also, of the opinion, and I think the reason I was saying that is because we sit on the real estate committee, which was previously the records track, and we're looking at all real estate, activities for all the enterprise. And this was not, anything new that was that we had to address. as we sit on the real estate committee, I would have liked to have seen if there were concerns during these previous 4 iterations, because this was number 5. I would have liked to have seen more discussion at that level. And
Understood.
utilize, because what I'm saying, getting to is, we should really be utilizing the committees. We made a recommitment to utilize the committee work and the committees, to help us cut back on our board members and our time and our meetings. So let's look at that. Just if we're going to recommit to that, then let's do it. And that's all. The only reason, in that spirit, that was why I offered that suggestion. Thank you.
Thank you.
But thank you.
Any other questions? Okay, agenda item 12.
Members.
Thank you, Mr. Elam. Agenda item 12, confirm the next regular board meeting date, time, and location. The next Central Health Board of Managers meeting will be held on September 11th, 2019, at 6 p.m. at the Central Health Administrative Offices, 1111 East Sarasota Chavez Street, Austin, Texas, 78702. As previously moved, the first public hearing on the proposed no new revenue tax rate will be held on September 11th, 2019, at 5:30 p.m. in Central Health's Administrative Office, 1111 East Sarasota Chavez Street, Austin, Texas, 78702.
Move adjournment.
Second.
All in favor, say aye.
Aye.
Thank you, managers.
Thank you.
Thank you, managers. Huh?
Now I saw that. 30, so.